So we're going to talk about a young lady. She's currently 20 years old, but she was 18 when she came to see some of my colleagues. She was originally admitted due to a 2-month history of unintentional weight loss, right lower quadrant and left lower quadrant abdominal pain, and changes in her bowel movements. And one thing I want to sort of state is that this young woman had a history of genital herpes and was currently well controlled on a maintenance dose of valcyclovir. So just want to bring that up as we move forward. So pertinent findings, fairly thin young lady. And the pertinent findings on the physical exam included tenderness, 2 palpation in the right lower quadrant, perianal skin tag, and overall thin body habitus, but no other major stigmata, and did not have any signs of active herpes infection at the time of diagnosis. These are some of her labs, just the things to bring up: mild anemia, but a normal BMP, hypoalbuminemic, mildly elevated inflammatory markers, thyroid and celiac were normal, fecal cal was a little bit up, infectious stool studies were negative. So pertinent lab findings, nutritional labs are fine. I want to point out that had previous EBV infection, low titers of varicella, so did require re-immunization, and PPD was negative. So in summary, the upper endoscopy was unremarkable. The colonoscopy only showed moderate to significant terminal ileitis, which correlated with what was found on histopath. And then when you look at the CTE, again, there is acute inflammation in both the terminal and distal ileum, very short segment of the sigmoid, although this was not really seen so much on colonoscopy, no abscesses, no penetrating disease. There was some question whether there could be low-grade obstruction, but nothing that just screamed out to the folks who were taking care of this young lady that there was actual stricturing. So, first question I was going to ask, and I wanted to see if the questions were here, but we'll talk about it in just a moment. So she was officially diagnosed with ileal Crohn's disease. She was actually started with induction therapy on a polymeric diet, so exclusive enteral nutrition, which she did stay on, and then went on 6-mercaptopurine, by the way, had normal TPMT enzyme levels. And they specifically avoided steroids because of her history. And then was vaccinated for varicella. During that time, she was on enteral therapy, so we didn't have to worry about immunosuppression with steroids. So within 5 to 6 months, got through enteral therapy, but really didn't do well, according to my colleagues. Worsened symptoms, abdominal pain, changes in stools, continued to have negative infectious stool studies. The only thing on endoscopy that was remarkable was mild chronic ileitis. The MRE showed persistent TI inflammation, but it was actually improved, and I actually reviewed the studies, and it indeed was significantly improved. And because of the active disease, albeit mild, the decision was made by my colleagues to decrease her 6MP and to start her on infliximab. So I'm going to actually go back and ask the panel. So what are your thoughts about a young woman and actually HSV? I mean, it was actually HPV, I realized, not HSV. So someone who has stable HPV in remission, or not remission, but quiescent, in this scenario, what would you all have done for the initial therapy, and what would you do in this scenario? So I'm just going to let folks sort of speak up, and then we'll go through a little literature.
I mean, I'll just start with the comment on the HPV, and it's interesting, the story of the steroids, but more importantly is the kind of added effect of 6MP, because of, to be truthful, I think we all feel that the viral world is really like EBV, HPV, is really the place where probably, not that it's per se contraindicated, but it wouldn't be the first choice of a therapy right. Is in a long-term maintenance scenario in a young woman with a history of HPV, especially with possible colposcopies, like other things that she may need in the future. And for sure, when I was adding a TNF, I don't see the logic in lowering. It's not a dose right. effect. I think it's just presence or absence of anything that can inhibit lymphocyte proliferation in the way I think about it.
Right. And I remember, because that was one of the discussions, and we'll talk about that in just a moment, I think the thought was they were trying to do combination therapy, trying to, sort of decrease the immunomodulator sort of load, so to speak. But I agree. Any other thoughts?
In general, I agree completely with Marla. The use of 6-MP with viral infection to begin with would not be my first thought. Going to a biologic sooner than later would be kind of the pathway I would most likely think about.
And I just want to add a point that IBD alone, actually, Susie Kane showed, this was like a decade ago, I feel, when biologics first came out, she looked at risk of abnormal cells on a pap smear, and IBD alone was actually associated with having abnormal pap smear, and then added the risk as you added immunomodulator, and there was a discussion about biologic, but back then it was all combination, so there was no way to really tease apart the added effect of the thiopurine.
And I have to agree. So there are just some slides, and these will, by the way, be available if anybody's interested. Looking at HPV and IBD, as Marla and David were bringing up, looking at different meta-analyses, and I think, the things that we worry about are not just the immediate infection, whether it's, quote, under control or not, but what are the long-term sequelae, cervical dysplasia, cancer, just, again, so knowing that there could be a connection, just having a diagnosis of IBD, but then adding immunosuppressive therapy. And so there was a meta-analysis here from a few years ago that, again, suggests that there's an increased risk of cervical high-grade dysplasia and cancer when you're on immunosuppressive medications, and the question becomes, what's worse, an anti-TNF, a thiopurine? And I think we could all agree that the thiopurines may actually cause us a little bit more pause. So here are just some of the ACOG and the ECHO guidelines that certainly go through, being especially cognizant in regards to screening, certainly worrying about the cervical sort of dysplasia and cancer risks. So then I'm going to go on with the clinical course of this young woman. So last spring, had improved GI symptoms, gained weight, abdominal pain went away, all great, right? But she then developed some very worrisome neurologic symptoms, foggy mentation, difficulty concentrating, failing grades, previously had a high GPA. The one kicker is I think she was going through some major issues at home and had some difficulties there. But still, with all this history, the primary team was certainly concerned about things like demyelination, possible lupus type of sort of prodrome. I will say that it's not on the slide, but they did the screen, nothing that would be concerning for an anti-TNF-induced lupus-like syndrome, and the MRI was non-concerning. Was diagnosed with depression and began treatment and actually did become better with some of these neurologic symptoms. And so, we've already had wonderful speakers, Lori Kiefer, Eva Sigathy, so I'm not going to go through this too much, but just a friendly reminder, especially with our teens, stressors, et cetera. Certainly we think of the organic, but also have to remember how crucial the psychosocial piece is, especially in a young adult woman who has numerous other sort of medical comorbidities that we have to think about. So further clinical course in the summer had therapy escalated to 10 per kilo from 5 per kilo, since GI symptoms would worsen a few days to a week prior to the next infusion, was continued on the 6-mercaptopurine. Symptoms were well controlled. The trough level was between 9 to 10. In the late fall, had repeat endoscopies that showed mucosal healing, which was good. So then, in 2017, she turned 19, lost her health insurance and was not aware, nor was she prepared for this. So we could all talk about transitioning, but we've had some of those discussions. But the bottom line is, due to losing her health insurance, had delays in getting her infliximab. So went approximately 10 weeks. I think it was actually closer to 11 weeks opposed to her 8 weeks, and then had worsening abdominal pain, loose stools. So she was then, when she got her insurance back, changed to Q6 weeks. 6MP was stopped because the primary team had said, you know, it's been almost 2 years, better stop it. They read the literature, which is good, or was reminded, and continued having abdominal pain and loose stools despite now a therapeutic trough of 21. And I will say, as a follow-up, I've subsequently been involved in her care. She had recent MRE that actually showed almost complete resolution, no significant inflammation, and her repeat scope showed minimal ileitis. So certainly endoscopically and radiographically has shown improvement in her disease. Other confounding factors, however, is that she's had multiple urinary tract infections, which led to C. diff, which we wonder may have also sort of worsened things. Had recurrence of her genital HPV lesions, and then with everything going on, I will say that I encouraged my colleagues to consult with infectious diseases and the OB-GYN. We did further STI testing. Luckily, everything was negative. So I think the questions for this panel, just looking through things. So again, with the therapies, I think we sort of discussed it. How would you have approached this? You know, how does one initiate the transitioning and transfer of care process? That's a long discussion, but I think there are pertinent things that we can learn here that I wanted to sort of highlight. The fact that she is a young adult. The entrance piece, I think when you look at transitioning studies, it clearly shows that some of the weakest areas, so to speak, in terms of knowledge of our young adult patients it's on sexual health and reproductive issues, and issues of financial sort of, or insurance-related issues as well. So I guess the sort of the flip question, if you guys had to look at the pieces that you would have changed, sort of what would they be right now? So now we have a 20-year-old young lady who's actually doing pretty well. She still has what she considers active symptoms, although we have signs of mucosal healing. So I think, one, what do we think is ongoing and what would we do next steps? And then secondly, looking back, sort of the take-home message for all of us here as pediatricians, what are the things that could have been done a little bit differently here?
So I think the case was handled quite well. I think with all of our patients, one of the major impacts on overall health, well-being, is really addressing those psychosocial issues up front. From a program where we initially had no psychologist to a program that has a psychologist and then lost their psychologist because she retired. The importance of having a team approach can really, I think, change the trajectory for our patients, especially having individuals go to places like Camp Oasis. And I'm sure everybody in this auditorium has had a very similar effect. The children are completely different when they come back into the clinic, how they perceive themselves, how they perceive their disease. It doesn't mean that life isn't hard, and doesn't mean that individuals outside of their disease don't have their ups and downs, but I think that we can make a significant impact in our patients by kind of addressing them in a holistic way, and really involving the psychologist, the social worker, the dietitian, et cetera, I think could improve the other symptoms that she might be having.
Well, maybe we can close the door. It seems like people are starting to party already.
Those people were agreeing with me. They shared that with laughter.
Yes, exactly.
So can I add, Sandy? I
Yes,
think
please
that
do.
one of the things we don't quite have a handle on is what is the best screening tool to establish whether a patient is indeed ready to transfer. I think that, as you know the work that you guys are doing, is that age is obviously the worst measure of transfer.
Yes, we all agree.
Some are forced due to practicing at freestanding children's hospital that you have to actually transfer at 18 or whatever. In Canada, I think you send them across the street, right?
I was going to say in Canada it's 18, correct, Dan? Yeah.
And so I think that we probably should take a better stance on whether it's the track score, whether it's the grit score, whether it's the resilience. It doesn't matter. I'm not proposing one or the other, but I think we need to figure out a way to say, you know what, early, not when she's losing her insurance at 19, but at 16 or whatever, whenever we feel is the right age, to say she's missing the toolkit, and whether it's on the track, it's the medication domain, she doesn't even know how to order her REMI, she doesn't know how to do insurance, which is a very classic one, and to know what her social support system. She seems like she may be a little bit of a wild child, so I'm not sure how much her family is involved in her care or not. And I think those are things that struck me, that she would be screened as an at-risk young lady, not in a negative, truly negative way, but as a way to say, I need to get my transition team coordinator or my NP or whoever she wants to talk to, who can help transition her correctly but early.
So how do you do it? Because I know that you've got the resources, and then I'm going to ask the audience a question about this as well.
So we are very lucky to have Lori Kiefer at Sinai, and she has herself, as you know, developed a self-efficacy scale, or the self-management scale, for both kids and young adults. And she's now transitioned that into the development of a GRIT score, which is gaining resilience through transitions, and it helps to identify, it's a score on 0 to 100, the higher the better, and her ability to screen a patient who is not going to handle that transition well, and starts them in a year-long, this is you have to stay in it for a year, and identifies them early and gives them really all these tools to build out the aspects of their weakness. Now that's ideal, but our goal is that the GRIT score will be in Epic, and or if you have another system, you could get it uploaded, and literally things will track into it. So I think that'll help. For those, a lot of people don't have this. I didn't have that at Cedars at this kind of level of access. So I think the goal is for anyone who's really an expert in this area or interested to make it available, and assume that most people don't have the resources to transition and identify at-risk individuals. Yeah.
And I appreciate you saying that, because I think folks will say, when you look at a lot of us up here on this stage, we are fortunate enough to have the resources. Show of hands, how many people in this audience have readily available access to a medical social worker or psychologist in your practice if you happen to have a young lady like this? Just curious. All right. All right, and then the second question is, how many of you have a specific plan in terms of transition readiness or utilizing some of the scores that Marla was alluding to in your practice with the young adults? Okay.
And do you, if they screen negative for whatever score you use, do you then give them the toolkit and not transfer them until they've passed the bar? So you do use that to decide how you're going to. That's great. I mean, that's what I'm saying, that it's one thing for us to fill out a score and then say, okay, go across the street. Thank you very much for your time. You're actually doing something to help improve that, to make it a smooth transition. Yeah.
Right. Because I have to say, as an aside, so how many folks have to, you guys are like, oh my gosh, when is she going to stop asking us questions? How many folks transfer kids when they're 18, and how many will keep the young adults until you feel they're ready to independently go to an adult GI? So do some of you come from institutions where you have to sort of transfer care at 18, or not necessarily? Few folks, okay. Because I think one thing I want to highlight as we sort of wrap up this question, I think sometimes there is a tendency when someone has this many complicated issues to say, wow, you're 20, you need to go to the adult GIs, and now, when these are actually the young adults who are probably the ones that need our help the most. So I think I agree with Marla. I think you need at least a minimum of a year, and probably starting the process earlier than later. And again, things like health insurance, quite frankly, I don't know if I understand the health insurance system. So to ask a 19, 20-year-old who's got an unstable social situation, we all recognize that it's not so easy. So anyways.
And just remember that you don't transfer a patient when they're active, because that's really difficult for them. And second of all is the idea that if pediatricians, for those of you who are holding on to your 23, 24-year-olds, those are the least prepared patients to transfer. You know, if they're 25 and they're still in a pediatric-oriented care, I could just tell you that we've measured it. They have the lowest track scores compared to 25-year-old who's managed by an adult provider. So I know we want to hold on to a lot of our patients, but it's really important because this is exactly what happens, not this particular,
Yeah. No,
but what
but
you
it is,
said
yes.
is exactly what happens to a lot of our patients.
Okay.